Fine. So I'm gonna just a summary of what I'm gonna talk about today. I'm gonna explain a little bit about the field of palliative care. This is my field of work. I'm gonna talk about emotions and emotional communication. I'm a social worker by trade. My expertise is in emotions. And I'm going to tell you a little bit about the distress that patients and caregivers tell us they face while living with a diagnosis of advanced cancer. And then I'm going to speak a little bit about some of the evidence-based psychotherapeutic modalities that are available for clinicians. But I'm also going to, throughout the presentation, I'm going to share some of the knowledge and that other patients have shared with us or that we have found in our research, hoping that some of the tips and suggestions that I give could be helpful. So let's start with palliative care. Just to give you just a brief historical information, the field was born in 1973 after the work of Elizabeth Kubler-Ross, Dame Cicely Saunders, Dr. Balfour Mount, that were exploring the needs of dying patients near the end of life. So at that time, palliative care was focused on supporting individuals who were near the end of life and had a particular focus and attention to their quality of life. But since that time, there's been a big evolution in the field, and now palliative care has a much broader scope. There's a very recent research that shows that palliative care is beneficial for patients at any stage of the illness, and now is provided in very different illnesses at different stages to patients of different ages. The current focus of palliative care is to provide the best quality of life, as I mentioned, for individuals at every age, at any point in their illness, for different type of illnesses, not only cancer. It can be provided when a cure is possible, it can be provided in advanced disease, and it can be provided at the end of life. But unfortunately, due to the roots of palliative care, at the beginning was so focused on the treatment of symptoms and the focus on quality of life near the end of life, that there's a little bit of stigma related to the word palliative care, and that not only our patients, not only some of the community members, but even clinicians in many parts of the world still only think about palliative care as an intervention near the end of life, which is quite far from the reality. And for this reason, a lot of institutions are changing their names, moving from palliative care to more supportive care, just to highlight that this is an additional treatment, this is additional support for our patient, in addition to what they are already doing with their oncology team. So what are the goals of palliative care? The goals of palliative care is to pay meticulous attention to symptoms. A lot of the times our patients have very little time with their oncologists due to the structure of our system. And in that limited time, patients have to review many different priorities, and they have questions, they need information. So symptoms are often addressed, but there's very little time given to symptoms. And when I talk about symptoms, I'm referring both to physical and psychological symptoms. So palliative care addresses what's happening currently in our patients, what symptoms, what psychological and physical symptoms that are distressing they may be having at that time. And they have the privilege of dedicating a lot of time to the treatment and monitoring of symptoms. And they also try to prevent new symptoms to arise, and they use an holistic care approach. So a palliative care team in large hospitals, although in remote communities might be different, typically include an interdisciplinary team. So there's physicians, nurses, social workers, occupational therapists, physiotherapists, pharmacists, spiritual care providers. And this team of people try to help patients do different things, manage symptoms. Some of the distressing symptoms that come up might be pain, nausea, fatigue, shortness of breath, can be assessed and monitored through this team. They have psychosocial support, and that includes emotional, social, and practical support. Emotional supports through psychotherapy, social support through linkage to resources, practical support through thinking through financial needs, transportation needs, and so forth. and plan for the future. That include advanced care planning, and I'll speak a little bit about this later on, help with clarifying values, beliefs, and making decisions about treatment, which are often very difficult. And again, as I mentioned, linkage to resources to plan better for the future. And they also have non-pharmacological interventions for patients that do not want medications to help with physical symptoms that might include nutrition, physical therapy, breathing methods, meditations, or relaxations techniques. So this is the Princess Margaret Cancer Center. This is the hospital I work in Toronto. And here I provide emotional support to our patients. And I've done a lot of research on the psychological dimensions of cancer. So this is the lens that I'm going to take today. And I'm going to tell you a little bit about what I've learned through many encounters, many encounters over 13 years with our patients and caregivers. I had the honor and privilege to sit in the same room with many patients and caregivers for psychotherapy through qualitative interviews, and I've conducted a lot of longitudinal and cross-sectional studies in this population. I should say I am not a cancer survivor. I don't have a direct experience of this, of what our clients go through. So what I'm going to talk about today is more telling you about what I've heard and learned from our patients and caregivers who so generously shared their stories with us. So before I go into that, I think I thought about this a lot on what I could present today. And before I speak about the experience of our patients and caregivers, I thought I would tell you a little bit about emotions. I'm pretty sure that today I'm going to tell you something that you might have not heard much about in the past, that might give you a different understanding of how our emotion system might work. At least I hope. The distressing events can obviously affect our emotion system, and a diagnosis of advanced cancer can be a traumatic event from some of the families that we support. Advanced cancer can bring up very difficult emotions in patients and caregivers, and these emotions can include fear, sadness, grief, shame, and anger. These are very normal, very valid emotions to feel in this stage of life, and are very painful and can be very threatening. So many of our patients don't want to feel these emotions, and it makes a lot of sense because they're painful, because they're threatening. So a lot of our patients tell us that they don't want to talk about their emotions because doing so will be upsetting. Other patients tell us, and caregivers as well, that they would try to best maintain a positive outlook. And these are definitely helpful and important parts of our life, but it's often less feasible when we face major life challenges. Our neurobiological system research really shows that we have two separate systems in our body. We have a cognitive system, a rational mind that tells us what's true and what's false, what's right or what's wrong. And then we have a feeling system that tells us what's good for us and what's bad for us. And it tells us through physical sensations. It tells us through feelings and emotions in our body. And our cognitive mind does not have the same information that our feeling system gives us. For example, it tells us through physical sensations when food is bad for us. We feel disgust, we want to throw up. Our cognitive mind has no knowledge of what's happening, but our body does. Or sometimes it might give us more complex information. When we see a snake on the floor, our body reacts to the snake before our cognitive mind even understands there's a snake there. Or sometimes we feel a particular look in our partner might make us believe that they might be angry at us, and that produces a whole feeling into our body telling us that there's something that is wrong. So it's a system that gives us important information that is not present in our cognitive mind. So I want to tell you about different types of emotions. And I think some of what I'm going to say next might answer even some of the questions that I received last night through some of the attendees today. So there are different types of emotions. One type of emotions, we call them primary emotions. Primary emotions are natural responses to the environment that are generated within our body. As I mentioned early, imagine the example of finding a snake on the floor. The emotion system scans the environment, sees the snake, produces an all emotional fear inside our body, and makes us react to the snake, jump away, move away, protect ourselves, even before our cognitive mind sees that there's a snake there. When I first started studying emotions, I marveled at this system that we all have inside us, because we don't have control over it. Our system reacts directly to the environment with emotions that are generated within us, and they have important information for us. I want to repeat that. It's a complex system of interconnected areas in the brain. So there's a physical component of it. We study it now, we know a lot about it. And as I mentioned, constantly scans and assesses the environment for us. And it scans in the environment for us to tell us what's good for us and what's bad for us. It identifies important things in the world, and it makes us aware of them. It prepares us to respond to them. So as I mentioned, it carries an important message that our cognitive brain does not have. It helps us produce a response. When we feel sad, we are crying out for help. It makes us more amenable to receive support. When we are angry, we are more able to put boundaries and protect and help us when somebody has wronged us, and so forth. And we only have access to this system through physical sensations, through how we feel inside our body. What are these emotions? These are emotions of sadness, of feeling alone. Our body tells us that we need social connections and makes us feel sad that we're feeling alone. Sadness of grief, which helps us to process the loss that we face in our life, or that we will face in our life. There's fear, for it makes us aware of danger and prepares us to respond to danger. It's that there's this empowering, assertive anger that helps us keep boundaries, protect ourselves, assert our needs. There's joy, which helps us move towards what's pleasurable, what's good for us. Shame and guilt, which help us understand if we have wronged others and if we have done something wrong to other people, and helps us correct our behaviors because we're social creatures. We need to be in social environments, and there's interest that guides us to what's more valuable for us. So these are positive, good, important emotions that we need to access to, because they're helping us to do something with our life. But then we don't have access to these emotions. We are socialized in our society to not pay attention to our emotion system. This is because our parents grew up in a time of our life where emotions were not studied. We didn't know a lot about them. There was a lot of stigma around them. So they couldn't take care of their emotions themselves, let alone helping us with our own. And to use the system, we need to be taught. We need to do it relationally with somebody else. So we tend to live our lives not into our primary emotions, but into our secondary emotions, what we call secondary emotions. There's different types of these emotions. And one type are emotions about emotions. For example, I am feeling alone, and a lot of people are not able to feel alone. It's a very difficult feeling. It's painful. It's suffocating. So a lot of people get anxious or get scared when they feel alone. So as you can see, the feeling that is in the body, that is responding to the environment, is that feeling of loneliness that is telling us something about our social interactions. They're telling us that we need more and that we need to somehow find a way to get more. But because we get scared of that feeling, we don't listen to it. So we are aware of the anxiety and the fear, but the anxiety and the fear is really superficial. Another type of secondary emotions are we call reactive or protective emotions that have a protective function. For example, a lot of men, the literature shows us more in men, get angry when they feel vulnerable, when they feel scared or they feel ashamed. They tend to react with anger. because the anger is trying not to make them feel vulnerable. Because when I feel angry, I don't feel sad. When I feel angry, I don't feel scared. When I feel angry, I don't feel vulnerable. The anger is very superficial, but there's a very vulnerable feeling underneath that needs care and attention that we don't reach to because we're stuck in our secondary emotion. So, as I mentioned, people do not want to get in touch with these primary feelings because are painful and they're threatening. And this often causes this feelings of hopelessness and helplessness. So we see a lot of people who are stuck in this feeling of hopelessness, who are stuck in this feeling of helplessness because they're trying not to feel what's happening underneath because it's probably quite painful. And the hopelessness and helplessness have this function. I don't have access. I can feel my primary feeling, which means that I can access the information that they're giving me. And it's very important information. So people tend to feel very hopeless and helpless that their needs will ever be met in life. They are stuck in this hopeless fear and the hopeless sadness because they are unable to process what's happening underneath. And it's not a fault. We're just like we're taught not to deal with these feelings. Sometimes the feelings are so painful that the entire system shuts down. And this is really how we understand depression. When there's very painful feelings happening and people are unable to process them, they tend to completely shut them down. But we can shut down one feeling selectively. When we shut down one feelings, we shut them out, we shut them down all. So depression really is understood as an absence of feelings. A lot of people feel what we call anhedonia, lack of interest in doing things. They feel like they don't have energy to do things. They feel like nothing gives them joy or pleasure. And it's because the system is shut down. There's no interest to guide discovery. There's no joy to go with pleasure. So there's lack of energy because we don't have motivation that comes from the anger and so forth. Other people try to control this primary feeling, and that usually causes anxiety. For example, worrying is a way of people trying to prevent feeling some difficult feelings. Sometimes people worry about being humiliated in social anxiety. People worried about being negatively judged, which would cause feeling of shame. People worry about possible danger in the future and feeling scared or feeling pain or feeling hurt. So they get anxious in the moment. But typically what happens is that these are all attempts at protecting oneself. People are stuck in the secondary emotions because primary emotions are quite painful. But then the secondary emotions become problematic on their own. People are angry, irritable, depressed, worried. They feel hopelessness or helplessness, and kind of like they are unable to come sometimes to come out of this state. There's another type of emotions that I'm just going to glide over very quickly because it's not important for us today, is what we call instrumental emotions. These are emotions that are used. They're not real emotions, if we want to say that, quote unquote, but are used to obtain something. For example, some people use anger to intimidate. Some people use excessive seduction to obtain attention. Passive aggressiveness is one of that, and so forth. These are not productive way of getting needs, because, and secondary emotion also are not productive way of getting needs because they're not really following the messages that are carried by primary emotions. And these instrumental emotions can be in awareness, so some people don't even know they're doing that. So when somebody is in distress, we have to kind of like imagine that this is going on. When we look at somebody, on the surface, we might see irritability, we might see anxiety, we might see feeling overwhelmed, we might see feelings of hopelessness and helplessness, we might see depression, we might see them being shut down. But this is just what's happening on the surface, because underneath, there's a difficulty feeling other more painful feelings that are important and that needs to be felt and processed and come up on the surface. This is like the feeling of loneliness, the sadness of the loneliness, the sadness of the grief, fear, and sometimes terror, which makes a lot of sense for some of our patients and caregivers, healthy anger towards what's happening to them, a feeling of shame and guilt, which also is often we see with our patients, Grief is because there's many losses. Lonely because sometimes our patients are not able to communicate their feelings to those around them. And we'll review this in a minute. And so they end up feeling alone, but they're not aware of this loneliness because they're stuck in their secondary emotion. So how do we help? And one of the things that I've learned through, I've done many years of psychotherapy and psychotherapy training, but one message, really distilling everything that I've learned, would be just be with pain. And pain is an important part of life, including emotional pain. It's difficult, it's threatening, but it's important. And being with pain means being with pain with people that can stay there with us. They're not trying to fix us or help us or moving us away from it. Just understanding that this is a part of the process and it's necessary. We can't avoid it. So in a way, don't just do something, stand there. Really, to say that pain can be fixed. Pain can be only be helped with compassion and with care, and allowing it to surface and caring for our loved ones who are in pain, the same way we would care for a child who is in pain. Let me give you just some data. But 1 out of 3 of our patients report some psychological distress. And this includes mainly anxiety, depression. So this secondary distress, this is what our patients report to us. They don't tell us that what's difficult is their primary emotions. They tell us that what's difficult is that they're stuck in their secondary emotions. And our primary caregivers report similar rates of distress or even higher. So in summarizing a little bit what we've learned from our patients, there's 4 areas where patients find a lot of meaning and a lot of distress. We have kind of like grouped these areas of distress in domains, and is disease management and relationship with healthcare providers, changes in self and relationship with close others, sense of meaning and purpose in life, and hopes and fears about the future. I'm going to talk about each one of them. The first one, symptom management, communication with healthcare providers. So we know that physical symptoms, particularly pain and side effect from the treatment, can, of course, cause an emotional response. Not only the physical discomfort, there's an emotional discomfort that is related to it. Particularly pain, we know that a lot of psychological distress really correlates with the presence or absence of pain and the intensity of the pain. And sometimes even waiting for symptoms to come up can also cause a lot of distress in anticipation. These are some of the symptoms that we know are distressing for our patients, for psychological distress. I already talked about that. Fatigue is one of the most common symptoms. It's a common side effect of treatment, particularly radiation. Pain is a common and distressing symptom. Difficulty sleeping, this is due to physical symptoms, sometimes keeping up our patients at night, but also psychological symptoms. Anxiety can keep up our patients at night, and sleep is such an important part of physical and mental health. But also some psychological symptoms can make us sleep too much, like depression, or at the wrong time. Shortness of breath is another distressing symptoms, nausea and vomiting, and also changes in physical appearance are difficult for our patients. And the symptoms can be overwhelming and distressing on their own, as I mentioned, but they may mean more to some individuals. For some individuals, they might be a reminder of the cancer. For some individuals, may be a reminder that some of their activities is limited now. Maybe a reminder of what might come ahead, what might come ahead. So they have meaning and they have emotions attached to it. And it's important that we acknowledge and care for the difficult feelings and the difficult meanings that are attached to the symptoms, to not dismiss them or to not minimize them. However, I also want to say that it's important to maintain healthy communications with the healthcare practitioners, because a lot of the symptoms that I mentioned in my previous slide are very often treatable and even preventable. And there's some of the things that our patients are told us that are very helpful to communicate, in that it's important to listen to one's body, to keeping track of the symptoms and the side effects, so that when when talking to one's oncologist, or one palliative care physician, there's a clear recollection of things that have happened, so that can inform treatment. Discussing symptoms with the medical team often is very important, to bring them up, and keeping track of questions and concerns between appointments, so they can be raised when meeting with a healthcare provider. There's a research shows that only 5% of cancers, only a very small amount of cancers, have pain that is very, very difficult to treat. Most other cancer-related pain can be prevented and treated, or can be alleviated at the very least. Another thing that is difficult, that our patients say it's difficult for them, and also our caregivers, is to navigate a complex system that is made of multiple layers. First of all, we just live in a very complex medical system to begin with multiple appointments, multiple providers, with very sometimes maze-like hospitals. I can tell you that we just renovated our hospital in the past 2 years, and I went and got lost myself. It's very difficult to navigate. There's a lot of bureaucracy, often linked to financial needs. Patients have to make, and caregivers have to make very difficult treatment decisions that have life or death implications. And there are also many communication challenges that happen with the medical system. This include long wait times for short visits. Sometimes patients have to wait very long time, not only when they're waiting for their treatment to happen or to see their doctor, but also sometimes between tests and results. This is where really, and then to meet with their oncologist for a very short period of time. And this is why tracking symptoms, writing down questions can really help with effective communications with the oncologist. A lot of our patients tell us that they lack confidence in the ability to understand information, and often devalue their own opinions, which is very important for when making treatment decisions. There's different communication styles between the patients and the healthcare providers. Some patients and physicians may just think about communications differently. Some patients may want more information. Some patients may want very little information, and healthcare providers can sometimes make assumptions about how much and what type of information a patient or family wants. There's power differential. Some of our patients tell us that it's intimidating sometimes to speak to their healthcare providers. They may find it hard to speak up when they have questions or when they do not agree with their care providers. And this can be because, as mentioned, there's different powers. There's a power imbalance between a provider and a patient. One of our research showed that, and this might surprise you, that even doctors, when they are patients, reported feeling the same. Some of the power differential really comes in the way when some patients might worry about upsetting their provider if they play a more active role or they disagree with them. Some people even worry that they will be seen as difficult or at risk and they feel like they're at risk to receive lower quality care. And this might be true for a particular group of people, like older individuals say they have a more difficult time because they say they grew up at a time when it was not acceptable to question your physician. And of course, often in our hospital system, really there is a lack of attention to emotional needs of patients. Some clinicians and some patients and some clinicians may avoid or find it difficult to talk about topics that are distressing or uncomfortable, including sexuality, disease progression, fear of death and dying, other mental health issues. And because of that, because there's that barrier, some of these issues may never be discussed. So these are some of the tips that come out from our research and from our patients: to be open, honest, and direct, to share questions, to inform the healthcare providers about how much information it's important for you to know, to always ask for clarification. It's important to let the healthcare team know at any time when more information is wanted or where less information is wanted, and to ask for clarification is an important part of treatment decisions. Share feelings, fears, and concerns if it's safe to do so. The right people with the right skills can provide very important and helpful support. Ask for resources like website, books, other reading materials. And all of our patients clearly communicate the same suggestion. Do not feel pressure to make decisions. Ask for another appointment, referral if you need more information or more time to make a decision. Take notes, bring support if available. This is all important information that can be useful, and clarify who is coordinating your care at the hospital. Use resources, ask for help in navigating the healthcare system. There's many individuals that have this role in us, especially in large cancer centers. This is one of the messages that came from one of our qualitative interviews, since that patients, if patients were asked what information would you like, or what message would you like to leave to other patients that come after you, and it's that you are the most important member of your healthcare team. It is rare that one provider can satisfy all needs. It's true that maybe the oncologist might not be the best person to provide emotional support. Sometimes patients feel hurt by that, but there might be other professionals that can do that role. Just aware of the time, I'm realizing that maybe I'm going too slow. So I'm gonna try to go through the next slides a little bit more fast. So this is the second domain, is changes in self. Changes to the body, as the body looks, feels, and performs. This is due to the cancer, sometimes the treatment, can affect our patient's self-esteem and sense of identity. These changes can have different meanings or create different feelings in our patients. For many reasons, our patients might feel a loss of other identities. Their identity as an employee, sometimes as a worker, as a caregiver, and can affect one's sense of self-worth. Things that used to strengthen our patient's self-worth, for example, having unique ability of skills that might be limited now, feel sometimes that this has been taken away, and that causes feelings of loss, of grief, or demoralization, which are understandable given the circumstances. And this inevitably comes with feelings of grief, that what was lost, it can be lost in the future, and feeling of grief for what was lost, and feeling of anticipatory grief for what might be lost in the future. Being able to allow one's emotions and talk about distress and process grief really provides an opportunity to re-examine self-identity and self-worth. A lot of our patients say that by allowing difficult feelings to emerge, to really talk about the impact of these changes into their life, really helps them understand that sometimes some of these changes matter more to them than they believed. Sometimes they re-examine priority, and they re-examine what makes them feel worthy and valuable in life. Some patients really talk about this as a transformation. A lot of our patients says that one of the silver lining of part of the process was to really have a different view of their own life. Changes in the body and changes in the course of the illness can sometimes increase needs of the patients, both practical, physical, and emotional. This often comes with fear and grief and shame and guilt. Some of the fears that are reported by our patients are of being a burden, of being dependent on their loved ones, of being abandoned or suffering, of feeling isolated, of feeling overwhelmed by emotions, of seeing others being overwhelmed by emotions, of thinking about the future. And the stress is often seen also in caregivers, and I'll speak in a minute on how we usually help individuals who go through this type of distress. Caregivers are often indicated as the invisible patients because they're often forgotten by the system. But as mentioned at the beginning, caregivers are sometimes often equally and sometimes even more distressed than the patients. There's a financial impact on the role of caregivers. There's sometimes social isolation. There's the burden of caring. But a lot of caregivers talk about how through the process of providing care to a loved one, they found personal growth. They experienced very positive changes in relationship, a lot of joy, a lot of refound closeness, and discovered new strength in themselves. Sorry, I'm just a bit over the time. I'm going to skip to the next through the next slides, but I can go back if you wish. I just want to leave some time for questions and answers. But these are some of the concerns specifically discussed by caregivers. Future-related concerns is, of course, as the patients, they facing continuous traumatic event, the patient's physical and psychological state affects how caregivers feel, the feeling of lack of control, and of course, juggling two worlds as caring for somebody, but at the same time, continuing working or caring for other dependents and so forth. Cancer is an illness that affects the entire family, and couples also experience changes in their relationship after a diagnosis of one of the partner. And sometimes a relationship that were in equilibrium before the diagnosis will have to renegotiate their roles in the relationship as time progresses. For example, particular relationship may have been worked very well in the past when, for example, two individuals are very independent from each other, and this could have worked very well for their relationship. But when one of the partners need more support, practically or emotionally, this can create new dynamics. Other people may have been used to taking on the caregiver role in their family or in their relationship, and now they feel they are in a position where they have to receive support from others. And this navigating these changes may be challenging because it comes with a lot of very difficult emotions and very difficult conversations. So the problem that I see in my psychotherapy studio with my patients, with the couples that I see, is that many patients and caregivers feel that they cannot speak openly about their hopes, their challenges, their difficulties, and their fears, making it difficult to have this important conversation. And the barriers to having these conversations is just a difficulty with emotional communication. A lot of the time is because a partner may want to protect their loved one. So a lot of the times I hear our caregivers and also our patients saying the same thing. I don't want to upset him. I don't want to upset her. It's already difficult for her. It's already difficult for him. I want to be strong. I want to be happy. I want to be this person for them. And this is definitely comes out of love for family members, but there's consequences in that every party feels distress and alone with it. When two people are feeling afraid and not talking about it with each other, both keep feeling afraid, but now they also feel alone with the fear. But when this very difficult feelings are discussed, then it's easier to face them because now they're faced together with other loved ones. So communicating feelings in a vulnerable way has the potential to bring closeness and positive growth in the relationship and face challenges together. Of course, this is in relationships where there's safety and people feel safe to talk about their feelings. And this can be partners, family members, friends, support worker, professionals, and so forth. But if you are supporting a person or family or caregivers that is facing advanced cancer, this is some of the questions that are important to ask. How has this experience been for you? How has it been for you to go through this? Whatever is the person going through, how are you feeling? What are your main concerns right now? I've been really worried about this particular thing that you're going through. Is there anything that you're concerned about? Is there anything that we haven't talked about that's been on your mind? Really providing opportunity for discussions. Is there any additional support that would be helpful for you? Main number 3 is about sense and meaning and purpose in life. This is another very important aspect that our patients talk about in our sessions and research, and that cancer may challenge life views and beliefs. It may bring people to think about how they have lived their lives and what meanings their lives have now. Some people feel distressed when their previous goals can no longer be achieved, while others may feel that their cancer has helped them to clarify what is really important to them. There's a change in the sense of meaning, in the sense of purpose, but it does not mean the end of the meaning of the purpose. It's just about reframing meaning and reframing purpose in a way that is more concurrent with the current life. We feel that our life meaning and life purpose has ended, but it's a feeling. It might not really be reality. The last domain is hope and fears about the future. Uh, this is the last part of my presentation, and then I'll just provide a few additional tips. But one of the most difficult challenges is looking into the future. Of course, there's a lot of uncertainty and unknowns. There's fear of recurrence, fear of progression, fear of losing independence and burdening loved ones. There's fear of death and dying. And there's our clients come with oscillating states of avoidance, of not wanting to feel these emotions, and then state of being overwhelmed when these emotions are too present and overwhelming. As mentioned, like a lot of people try to move away or not think about these difficult things and stay positive, or not think about it, but find it really difficult to do so, of course. This happens until some of our clients arrive to what we named the tipping point, when there's new physical symptoms, new limitations, changes in treatment, there's progression, where at this point it's very difficult not to think about some of the things that are laying ahead. And there's questions that come up that they have no simple answer and may trigger very, very strong emotions. There's a sense of urgency to address life's issues at this time. There's heightened awareness of the precious and fleeting nature of time. And this may also bring love, hope, and gratitude for life, as well as loss, grief, anger, sadness, and worry. These are all important, valid, normal feelings at this stage. Reactions may be complex, may fluctuate, and have both positive and negative aspects at the same time. Not engaging with the negative aspects will prevent us from finding the positive parts of it as well. Many patients report the fear of losing hope. However, it's possible to face the future, maintain hope, or reframe it in a realistic way. It's about balancing hopes and fears. It's about living in two worlds. It's like patients have now the very challenging task of engaging with life meaningfully while at the same time facing the future and facing mortality. We term this double awareness, this ability to think about the future, to plan for the future, to deal with emotions related to the future, but at the same time engage with life in the present and live meaningfully, which is possible to achieve when we change our relationship with our emotion system. It's like playing, one of our patients said, it's like playing two chess boards. I'm playing one game with life and one game with the future, and both very complex. And sometimes there's needs support to play both games at the same time. This will allow us to plan for the future. And just a few, I'm just going to skip this part. I'm just aware of the time. I'm so sorry. I think I just moved too slow, but part of the ability of thinking ahead is to plan ahead. Advanced care planning is the process of making important decisions about the future when patients and caregivers are feeling well and are able to engage in these discussions, because sometimes it's very difficult to make multiple decisions at the same time when we are also dealing with other practical and physical symptoms. Many clients say this is so depressing, but after they go through the process, they really tell us that they feel a sense of relief for having gone through the process early on. So how do we help? This is just last two slides to give you with my comments on all of this. Emotions are painful, and it makes sense that most people do not want to feel certain emotions because they can feel overwhelming and they're painful. Often our friends and our loved ones and even our healthcare providers may encourage patients to be positive and not feel emotions because they are human beings. It's difficult for them as well to stay with difficult feelings and difficult emotions, and everyone is able to do so. And while it's painful, it's helpful and sometimes necessary to feel and express these difficult feelings to people that are supportive to us and that are close to us. We can change relationships in a positive way towards our emotions. And this is really what does the trick, is having a different attitude towards our emotions, seeing them as a very important thing of our life that have an important message for us, then having a caring attitude towards our emotions, like a child or a friend who is in need, and understanding that is important. And they always pay back. At the bottom of a very difficult emotions, there's a very important message and a lot of transformation that may generate from that. However, we have to say that there's a difference between distress that is normal and valid and distress that is problematic. Sometimes our clients are stuck in their secondary emotions. They're stuck in depression, they're stuck in anxiety, and this needs treatment. And it needs a professional to help them deal with this superficial distress and process more difficult and painful emotions. When the distress is too much, however, it's also wise to release it a little bit. We don't want to feel overwhelmed. Mindfulness, meditation, these are some of the things that help. Distraction. We can engage in both mastery activities and pleasurable activities. This really usually distract us from difficult emotions, doing something we like, doing something that makes us feel productive, asking for support, reviewing if what we're and what am I thinking, is it really correct? Does it really match reality? Breathing, these are all things that help. Last slide. How do we help? We be versus trying to do something. We offer compassion, silence, words of care. Try to avoid the writing reflex, the reflex to want to fix it, and have active listening. Just listen, don't talk, don't express opinion, don't offer a solution, don't judge, don't assess. Just communicate empathy, communicate your understanding of the feelings, that the feelings and the experience make sense and is valid. And this is different than agreeing and disagreeing, just about entering our patient's reality and trying to understand how they feel. I'm going to stop here. I do have some suggestions for psychotherapeutic interventions, but if there's questions, I'll take them. Yeah, so my role is my expertise and practice is more of like providing a psychotherapeutic support to patients. So I can't really, I don't have a lot of knowledge of expertise of what oncologists might do. But as I mentioned, like it's always important to ask your oncologist to bring up these issues to them, to your healthcare team, and ask if there's multiple professionals that can help. The oncologist, sometimes patients see the oncologist as the only person to go to with every issues, and sometimes they feel disappointed that their oncologist cannot provide everything they need. But we understand that it's limited time, but there's other professionals available for difficult things, for many different things. Nutritionists available for issues with diabetes. There's other professionals that would care for heart problems and so forth. Will be important to, I guess, find out who will be the person that coordinates the care, so that can be like a contact person. I guess the main one for me would be to try not to dismiss patients' distress. Patients' emotions are an important part of the process. And sometimes patients are very vulnerable when sitting in a hospital room, maybe receiving difficult information. A lot of our patients say that sometimes they feel like numbers and they feel like their emotional needs are not really taken into consideration. So that's arguably one of the most impactful interventions at a low cost. If we think about how much cancer treatment costs, really providing silence and listening and understanding and compassion can really do a lot of good things to our clients. Yeah, so well, that's I can answer in two parts. So depends what anger, as I mentioned earlier, sometimes anger it's common in our patients, and it means more than what we see. We might see a patient being angry or irritable, maybe like exploding at the smallest thing. And sometimes this is a consequence of more medical component, biomedical components. Sometimes steroids that are part of treatment can do that. So it would be important to understand that this is just like our body reacting in a way that wouldn't react normally. and it's just due to the medication. But sometimes anger can be a sign of something else going on. Sometimes there might be underlying sadness or grief. There might be underlying fear. And these are very difficult emotions to feel. So sometimes becoming angry is it's easier in a way. So if the anger is not too disruptive, then what I would suggest is that we look at the anger in that way. What else is going on underneath? Are you feeling, I see the anger, but maybe the anger means something else, means that, you're suffering. Maybe the anger means that there's something else going on underneath. So compassion is one of the ways to maybe let the other emotion eventually come up, to understand that our partner might be going through something difficult, but also assert boundaries. Of course, as caregivers, also sometimes it can be distressing. So if the anger becomes too problematic and sometimes too much, I would suggest to speak with a member of the clinical team that sometimes can help with these conversations and can help one of the partners that is expressing a lot of anger to really understand what's going on underneath that. Sometimes it's like we see the anger and it's valid. It's part of it. Anger is one of the stages of processing grief. And sometimes we have to understand that it's part of it. It's normal as long as it's not affecting us. But I'm imagining that with the anger, there's also a lot of pain and a lot of hurt, a lot of fear. And the anger might just help not feel those feelings. So when we see the anger, we may think maybe there's a lot of pain or there's a lot of fear underneath. Does sometimes help to see it differently.
Unfortunately, everyone, we're a little bit over time. Carmine has to go. I will be here, though, sticking around if I can help with anybody with any questions. Again, thank you so much, Carmine. That was a great presentation. Carmine, sorry. That was a great presentation, and we really, really appreciate your time today.
Thank you very much for the opportunity.